Blood starts its journey from left ventricle with each contraction of the heart. It flows smoothly in the lumen of arterial tree because of the presence of endothelial lining, which forms a watertight barrier between the blood and the underlying intima. This watertight endothelial lining is breached by certain common predisposing factors, which include smoking, advanced age, uncontrolled diabetes, high cholesterol level, hypertension, strong family history, which denude the endothelium and exposes the matrix. This invites platelets to come together and form a clot called white thrombus. This triggers a chronic inflammatory reaction in the intima, which results in increased permeability and leakage of lipoproteins and cholesterol into the subintima and formation of atheroma. Cholesterol continues to accumulate and the atheroma enlarges in size. However, there is a dense fibrous wall which separates the atheroma from the underlying bloodstream. As long as the atheroma is well contained by fibrous wall, an individual is asymptomatic and there is no myocardial ischemia at rest. However, upon exercise, angina sets in. There will be ECG changes in the form of ST depression. This is called stable angina. Typically, this angina will disappear upon taking rest. When the covering fibrous capsule thins down, the atheroma ruptures. It exposes the submucosa directly to blood cells. Atheroma is highly thrombogenic. It attracts RBCs and the result is a red thrombus. When the clot enlarges, it starts compromising the lumen. Angina at rest starts. Now the patient really goes into an acute coronary crisis, and this is called acute coronary syndrome. There are three scenarios under this category. The first one is unstable angina, where there is subendocardial ischemia. ECG will show ST depression. However, troponin will be negative because there is no infarction. The second category is non-STEMI, where there is subendocardial infarction. ECG will show ST depression. That is why this is called non-ST elevation myocardial infarction. Troponin will be positive because there is infarction. As the clot expands, it may near totally or totally block the lumen, resulting in massive heart attack. There is a transmural infarction. ST segment will show classical elevation and T wave inversion, and of course, troponin will be positive. The real threat to life following an event of myocardial infarction occurs in the first 24 hours. The most common complication is arrhythmia, followed by cardiogenic shock and cardiac rupture. When the right coronary artery is affected, it involves SA node and AV node. The outcome is either bradycardia or heart block, either incomplete or complete. When the left coronary artery is affected, the opposite event happens. It's because of repeated re-entry phenomenon of electromechanical impulses. The outcome is the supraventricular tachycardia. It may go on to ventricular fibrillation, and sometimes it may end up with asystole. If myocardial contractility is compromised, water logs in body. It affects two major organs. Accumulation of water in lungs leads to pulmonary edema. Hyperperfusion of kidneys leads to renal failure. Rupture of the cardiac muscle depends on the area affected. If transmural infarction of the wall, it may lead to rupture of the heart and hemopericardium. Interventricular septum leads to ventricular septal defect. Any papillary muscle might lead to mitral regurgitation or tricuspid or aortic regurgitation.